Hey, so hello everybody. So in this we're going to talk about sepsis. I know that most of you have, looked after a lot of septic patients. So I'm going to concentrate first on talking about the new, now not so new definitions of sepsis, and then spend a bit of time on the background and the pathogenesis of sepsis and how sepsis actually causes organ failure. And then at the end, I'm going to quickly go through the main principles of treatment of the different organ failures and of the initial management of sepsis. So sepsis is really the response of a host to infection, and it's a dysregulated. So the definition I put up there is the new definition: a life-threatening organ dysfunction caused by dysregulated host response to infection. So we don't talk about septicemia anymore. We don't talk about severe sepsis anymore. SIRS is out. And this is just really a situation where the natural defenses of the organism are overwhelmed by sepsis and actually become harmful to the patient themselves. And the picture there is of a limulus crab, and that just really shows how very old the body's response to sepsis is from an evolutionary point of view. So animals have been evolving mechanisms to cope with infected microorganisms over many millions of years. And so the structure that we have now is like an old house that's been altered many times. So there are a lot of redundant and additional pathways that happen, and it's become extremely complex. But remember, this isn't the normal response to infection. This is an abnormal response. It doesn't often happen, but when it does happen, it's devastating for the individual concerned. The limulus crab, out of interest, is an organism that hasn't changed for many millions of years. It's a big animal, as you can see, and it has the unfortunate ability to clot its blood the moment it's exposed to any microorganisms. So that helps the organism protect itself from the microorganisms. But that, unfortunately for the crab now, its blood is being used by laboratories all around the world to test for the limulus assay, using the limulus assay for antitoxin or endotoxin. So it's a species that is now becoming endangered because of its ability to control infection. So the incidence of sepsis has recently been reviewed, and you can see now that annually nearly 50 million people have sepsis in the world, and it causes 11 million deaths per year, which is about 90%, a significant number of global deaths. And the majority of those are in the blue parts of this map in developing countries. But the good news is that the incidence of sepsis is falling and the mortality is getting better. And with early management, as defined by the Campaign for Sepsis guidelines, more survivors are occurring with severe sepsis. So one of the latest sepsis definitions included a set of guidelines for recognizing sepsis earlier, because as I'll come on to later, what's crucial is that the sepsis is recognized early, and so that initial management can happen as early as possible. So it's always in the setting of infection or suspected infection. If you have a response in this, there's a set of recognitions for emergency units and wards of a quick SOFA of more than 2. So the quick SOFA is a quick bedside score on the status of a patient. And patients have a respiratory rate of more than 22 a minute, or blood pressure of less than 100 systolic, or a drop in GCS, any of those things happening, 2 of those things happening, plus the evidence of some evidence of sepsis or suspected sepsis, you have to regard this as possibly sepsis and a need for intervention. And those parameters weren't just sucked out of somebody's thumb. They are from several very large trials in sepsis, have been defined as the earliest markers of mortality in sepsis. In ICU, we have more complex patients and we have more data to make a definition. So in ICU, the recognition of sepsis is a 2-point increase in a SOFA score. Again, in the setting where new sepsis is suspected. And this mere change automatically carries a 10% mortality. So the SOFA score you're familiar with, we use it a lot in ICU. It's a very old score, a very simple score, just using one parameter for each organ failure. But what's useful about a SOFA score is that it actually predicts mortality quite accurately in individual patients. So a patient whose SOFA score is going up has got an increased risk of dying, and a patient in ICU SOFA score goes up by 2 or more points may have a new source of sepsis and be developing new source of infection, be developing sepsis in that time. So septic shock is a subset of sepsis. It's a particularly lethal subset of sepsis, and that's defined now as a circulatory, metabolic, and cellular derangement. And the definition is the need for vasoconstrictors to maintain a mean blood pressure of more than 65 millimeters of mercury after the patient has been adequately resuscitated. So this is not the same as the systolic of less than 100 in the recognition. Many of those patients will achieve a normal blood pressure with fluid early on. So it's after adequate fluid replacement, as indicated by some dynamic measurement of fluid responsiveness, indicating that we now have moved into septic shock. And at the same time, you need to have a lactate of 2 or more. So septic shock has got a mortality of 40%. So it's a very lethal condition. Now, where does sepsis come from? So in the community, the most common source of sepsis, the lungs. The lungs are our weakest point from a infection point of view. And then going down the list, the next most common source is an abdominal infection, say from a perforated viscus. And recognizing where the source of sepsis is important because it helps you choose your empiric antibiotic. If you're standing at the bedside in ICU, you can think about the big 5, as these are the most common likely sources of sepsis in an ICU patient. So the lungs, again, are the most common, a ventilator-associated pneumonia, or an abdomen. And it doesn't mean that the patient needs to have had anything wrong with the abdomen before. Some conditions can arise de novo in an ICU patient that involve sepsis in the abdomen. A wound, a surgical site, the central venous lines, and the urinary tract. And although the urinary tract is very commonly colonized and infected, it quite rarely leads to sepsis per se. So although this is a very complex system that's activated by the inflammatory response, basically you can simplify it down to any microorganism causing an explosion of mediators that amplify the response. And this leads to really 4 main mechanisms of organ damage. There's endothelial activation, there's generation of nitric oxide by inflammatory cells and endothelial cells, there's damage to the microvasculature resulting in poor perfusion, and there's direct impaired mitochondrial function. So this is all initiated by what's called the innate immune response. So the innate immune response is the part of our immune system that can react to any threat. It doesn't have to ever have encountered that particular microorganism before. You don't need any memory of the microorganisms. And the first thing that happens is that the organism releases pathogen-associated molecular patterns. So these are parts of microorganisms that we have embedded the ability to respond to when we have that present in our bloodstream. So it can come from any microorganism, and it's recognized by receptors both in the blood and on the surface of our immune cells that recognize these PAMPs. Now, there's a big genetic variability between different individuals as to how they respond to that sepsis. And if you think about it, that is probably protective of a community. So any community of individuals who are exposed to a new pathogen or like a epidemic, some will have a very strong response and survive. Some will have super strong response and get sepsis and die, and others will have a very weak response and may not be able to overcome the infection. So that variability in the population gives us the ability for some individuals to survive almost any epidemic. So the most common microorganism, of course, is bacteria. And the most common bacteria to cause infection are the gram-negatives. And they really cause infection by activation of the lipopolysaccharide. So this is part of the cell wall of gram-negatives. And then you get other substances, including derivations of gram-positive organisms that initiate the inflammatory response. And then the pattern recognition receptors are mainly receptors on the cell surface of inflammatory cells, like toll-like receptors, node-like receptors, and TREM1. So all of these can, in different ways, activate the innate immune response, responding to the cells. And this is just a diagram just illustrating how the various toll-like receptors initiate a response in the inflammatory cell. So, for example, toll-like receptor 4 is a receptor that particularly is triggered by the attachment of a gram-negative organism to it. So the toll-like receptor 4, in this case, will initiate a response in the cytoplasm of the inflammatory cell, and that will go on to activate a substance called NF-kappa B, and that will initiate the synthesis de novo of the inflammatory substances that are generated by the inflammatory cell. So you get a production of a whole lot of cytokines initially, and then later other mediators that initiate and perpetuate the inflammatory response. So you have this cytokine and mediators storm, which leads to other pathways being activated. And so this whole process becomes amplified, rather like a musical amplifier, amplifying a very small current into a very large sound. And then the actual damage of host cells also can perpetuate and initiate this inflammatory response. And this is how, for example, ischemic tissue without any microorganisms can also initiate an inflammatory response. So this diagram, I think, shows it very nicely. This is meant to be a capillary here, just showing the endothelial cells, and this is an inflammatory cell which is responding to these gram-negative bacilli or these gram-positive cocci, attaching to toll-like receptors 4 and 2 respectively, activating NF-kappa B, and then that causes the cell machinery to start generating the inflammatory mediators. And the first one that comes out is TNF-alpha. That appears within about 15 minutes of exposure to endotoxin. And then interleukin-1, and then interleukin-6. And interleukin-6 it takes a bit longer to come up, but it stays for longer. So if you are going to monitor inflammation, probably interleukin-6 is the best mediator to actually measure. So this whole process now of cytokines then initiates the inflammatory response. Now, if this capillary happened to be associated, say, to an abscess, it would be doing exactly the right thing. It would cause the endothelial cells to be activated, which will then attract neutrophils. The neutrophils start to stick to that part of the endothelium and can now extrude themselves into the tissue near that capillary. At the same time, the endothelial cells release nitric oxide, which causes vasodilatation, so to get more blood supply to the abscess. But what happens in sepsis is that this starts to happen all over the body. So you now have a global response to infection, which should be really localized. Now, the endothelial also reacts in a different way, is that it starts to shed the glycocalyx. So the glycocalyx are this is an electron micrograph of a capillary showing these fronds of glycoprotein that float in the bloodstream. And these fronds are very, very fragile and ephemeral. They disappear very, very quickly. What happens in Matthew, your mic is on. And these fronds then disappear. And the main function of this, we think, of the glycocalyx is to actually prevent fluid from escaping from the cells. It actually prevents the extravasation of some of the albumin from the cells. So loss of the glycocalyx results in increased permeability and edema. And when this occurs throughout the body, you get the septic response. So you have increased endothelial permeability and shedding the glycocalyx, the generation of nitric oxide, and then mitochondrial. The microcirculation is quite severely perturbed in severe sepsis. So what happens here is that you get, this is a normal microcirculation in sepsis, and it's like bypass a lot of the tissue. A lot of microthrombi, and this causes localized areas of ischemia, which may be one of the causes of organ failure that we see. We also know that in sepsis, the mitochondria don't work well, so that in late sepsis, you get an actual increase in oxygen demand because the mitochondria are not using oxygen. And this may be a mechanism of organ dysfunction in severe sepsis. Now, what happens later on in sepsis is this immune suppression that many patients who survive their initial bout of sepsis, we've also seen patients that we've resuscitated successfully and think that we've done a good job, who've gone on to get one infection after another in ICU and sometimes succumb to those infections. So this cartoon just shows possible outcomes of a patient with severe sepsis, either an early death that occurs because you haven't been able to control the initial bout of sepsis, or the inflammatory response goes up and comes down and the patient survives. And then other patients actually then go into this immune paralysis and are prone to further infections, so that they have this seesaw course in ICU. So patients who are in ICU become subject to organisms that don't affect you or me. We see patients with these organisms every day in ICU. We don't get infected by them. These are basically low virulent pathogens that are very harmful to immune compromised patients. So I'm going to just now talk about the different organs and how they respond to sepsis, and starting with the cardiovascular system. You have septic shock. So you have really three components of septic shock. There's initially hypovolemia due to the capillary leak. So most patients will early on respond to a fluid blood bolus. And then the predominant thing is that you get this widespread vasodilatation or vasoplegia. The body just doesn't seem to have any ability to vasoconstrict. And then, although you often have a high cardiac output, you actually have myocardial depression. So the myocardium itself is suppressed and downregulated. And although you have the high cardiac output, is just really because the heart has nothing to pump against. It doesn't have to do any work to achieve a high cardiac output. So different mechanisms have been proposed as to why the myocardium is suppressed. Now, about 20 years ago, there was a landmark paper published by Manuel Rivers, who showed that he could improve survival by early and aggressive resuscitation in the emergency room. Previously, people had tried goal-directed therapy in ICU, and it basically didn't work in sepsis. But his key, I think, was that he realized that when patients had presented, they need initial and rapid resuscitation, and he gave patients IV fluids, dobutamine or noradrenaline if the blood pressure is down, and blood to keep the hematocrit above 30. And he did this to try and achieve a central venous oxygen target saturation of 70% or more. And doing this, he was able to show a decrease in mortality from 46% down to 30%. So this was very, very encouraging. And subsequent to the Rivers study, a number of other studies were done looking at goal-directed means of resuscitating patients from sepsis. And to everybody's surprise, it didn't actually show a improvement in mortality. But this was probably because these later studies were done in patients who were getting normal resuscitation that had become accepted practice by everybody. So the fact that these studies failed, in a sense, does not mean that the basic principle of early resuscitation is not valid anymore. So the other way that sepsis affects an organ system is the effect of sepsis on the respiratory system. So that's manifested by ARDS, acute respiratory distress syndrome, and that's mainly due to increased permeability of the lungs capillaries, resulting in fluid in the interstitium, and the lungs become heavy and invaded with white cells, and increased hypoxia and tachypnea. A little bit later on, usually not in the first days, patients with sepsis go on to get renal dysfunction or renal failure. And that's associated with oliguria, tubular dysfunction, tubular ischemia, and an increase in the mortality of patients. So once someone's got established renal failure in ICU, we know that the mortality is way up in the 40% and more group of patients. How's the liver affected by sepsis? Well, that's not always so obvious, but we do know that in septic shock, the liver has extreme ischemia, and that leads to a long-standing damage to the liver and a gradual rise in the bilirubin in unresolved sepsis. And then just as a side, I put in cirrhosis there because patients who have a cirrhotic liver and who are infected and have sepsis do exceptionally badly. I mean, so badly is that the presence of cirrhosis and septic shock is really usually in our hands an indication not to go on with aggressive therapies such as intensive care. And then one of the sad results of sepsis, it's called SAD, sepsis-associated delirium, is this delirium, which is probably caused by cytokines crossing the blood-brain barrier and leading to edema and leads to delirium in patients with sepsis. So that may be one of the first signs of sepsis. It can occur later on in ICU, and it is associated with long-term cognitive dysfunction and an increase in mortality. What also happens if patients stay in ICU for a while, around about a week of sepsis, results in this peripheral weakness due to a neuropathy and a myopathy. Again, that's something that leads to a very prolonged recovery and a long stay in ICU trying to wean patients. So that's so much for the mechanisms of sepsis and the different organs. I'm going to just quickly now look at the Surviving Sepsis Campaign guidelines. Most of this will be fairly familiar to you. This is the latest edition of the Surviving Sepsis Campaign guidelines. These are definitions that are drawn up. They are consensus definitions that try to use evidence-based studies to make recommendations, and I've sent the link to you on WhatsApp. So I do recommend reading this because they not only cover the management of sepsis, they really give a kind of cookbook for managing all patients in ICU. And then just recently, the Surviving Sepsis Campaign has issued this 2018 update, which is a short bundle really emphasizing how important it is to initiate management in sepsis. So this recommends that within 1 hour of the patient actually presenting to an emergency unit, you should measure the lactate level, you should obtain blood cultures, you should administer antibiotics, you should give a bolus of crystalloid, 30 mils per kilogram, but then don't go on just giving fluid after that. And then if the patient's hypertensive, to provide infuse a vasopressor such as noradrenaline or adrenaline. So just back to the 2016 guidelines, it's very important to very early on to try and make an anatomical diagnosis of the sepsis, because this helps you guess which empiric antibiotic to give and to start to plan for source control. So early source control is extremely important. It's very important, for example, if the patient's got sepsis and has got air under the diaphragm, that you don't now just decide to do a CT scan to make sure you need to take the patient to theatre and deal with the source of sepsis. If it's an infected device in the patient, you need to remove it as soon as possible. Antibiotics are key. So removing the source of sepsis and treating with antibiotics are the two things that we know really work in sepsis. So antibiotics should be broad spectrum, but appropriate to whether they are community-acquired or hospital-acquired infections, and they should be administered within 1 hour of the diagnosis of sepsis or infection in that, for that matter. And there should be no delay. So you may have seen this diagram before from Kuma's article. What he did was he looked at a huge number of patients from medical insurance companies. He got this data, and he looked for situations for how long the delay was between a positive blood culture in a hypotensive patient and the administration of an appropriate antibiotic. And what he was able to show that there was a very clear correlation between survival rate and the duration and the time it took to give the appropriate antibiotic. So if you look at the survival rate, so if you got an appropriate antibiotic within 1 hour, survival was over 80%. And if you look down here at more than 12 hours, the survival rate is down about 25%. So there's a huge difference. So it actually translates to an increase in death rate of about 7.6% for every hour that an antibiotic is not given. So one cannot stress how important it is to give antibiotics early. So giving fluid initially is recommended as a bolus. Now remember, this is designed for emergency units. It's not places where they necessarily have the ability to do sophisticated ultrasound or other dynamic tests for volume status. So basically for everybody, when they present, it's recommended 30 mL per kilogram of crystalloid fluid for resuscitation. The evidence for this is not that strong, but it's what is currently being recommended as a general, and there's a lot of debate about it, and some of my colleagues don't agree with this, but I feel that, you know, if you're going to have guidelines, they have to be firm and they have to be there that this be available or implementable by everybody. Recently, there's been a study in septic shock patients showing that in actual fact, balanced salt solutions such as plasmolite B or Ringer's lactate actually have a lower mortality than the use of pure saline. Remember, in the USA, it's mainly saline that's used, and that's available. So the vasoactive agent you use is, for most of the world, is norepinephrine or noradrenaline. We don't have that licensed in South Africa, so we use adrenaline. There have been a number of small studies showing that the mortality for adrenaline versus noradrenaline is about the same, and we're fairly comfortable with giving quite big doses of adrenaline, but clearly, particularly in older patients who are prone to arrhythmias and tachycardias, it probably would be better to use noradrenaline if it was available. So if your initial vasopressor is failing, you can add vasopressin, although that's not been shown to actually improve mortality. So what blood pressure should you aim for? Should you aim for a higher blood pressure in patients who are older or hypertensive? And the evidence is no. And this is a study where they divided septic shock patients into two groups, randomized them to a target of more than 70 of 75 versus a target resuscitation of 65, and they both did much the same. So for everybody, we titrate our vasopressor to maintain a pressure of 65, and you don't want to go more than that. You want to give as little vasopressor as you need to. Steroids have been tried in sepsis for many, many years, and they have always been controversial. What we know for sure is that high-dose sepsis, like a gram of methylprednisolone 4 times a day, increases mortality. The dose we're using now is 200 milligrams a day in divided doses, always a constant infusion. And the evidence for that is fairly slim. And I put there two studies. The last one is by Nunn, who's one of the protagonists of sepsis, showing that that there was a slightly improved survival giving steroids in severe sepsis, and that's associated with a shorter ICU stay. But the downside of steroids is that it may increase later infections, impair immunity, and we know it does increase the weakness that ICU patients have. What certainly does happen when you give steroids is that you are able to come down on the dose of inotropes and shorten the duration of inotropes to sepsis, which on the face of it seemed like a good thing, but it seems that later on the side effects of sepsis cancels that early benefit out. And so some patients may survive their septic shock with use of steroids, but only that could go on to then dying of other causes while in ICU. And then lastly, just to mention this condition of PICS, or post-intensive care syndrome, which patients with sepsis are particularly prone to. And this really consists of 4 things. There's physical weakness. So almost everybody who's been in ICU more than a few days is profoundly weak, needs a lot of rehabilitation. But more serious than that is that a portion of patients, and particularly the patients who've had delirium from sepsis, suffer from long-term cognitive dysfunction. So that can be a particularly bad outcome, particularly in older patients. A lot of patients who've been in ICU for any length of time have emotional problems and have severe post-traumatic stress disorder. And then what's also not recognized that many patients after they stay in ICU have unexplained chronic pain, back pain, limb pain, and are quite severely impaired by this. And it's not only the patients that are affected, you get quite marked family disruption after a period in ICU, particularly with sepsis, because of the stress of going through having a relative in ICU. And even if their relative survives, they're very pleased, but then they have to deal with an individual who can't think properly and who's very weak and needs a lot of caring. So this can be a particular problem for families. So now the philosophy of ICU is becoming family-centered, is becoming more prevalent in an attempt to support families through the ICU stay of their relatives. So that's really, just to summarize what this lecture is about. Sepsis is a dysregulated host response causing organ dysfunction, and it's recognized by either a 2-point increase in the quick SOFA score or a 2-point increase in the actual SOFA score. Septic shock is a mean blood pressure of less than 60, despite adequate fluid resuscitation or the need for inotropes to maintain that pressure, plus a lactate of more than 2. The key to management is immediate recognition, source control, fluids with crystalloids. I've omitted to mention that the artificial colloids are associated with increased mortality. It shouldn't be used. Noradrenaline is the recommended first-line vasoconstrictor, then adrenaline or vasopressin. The role of steroids is doubtful. And then if you want a nice review of what I've been saying, you can have a look at this narrative review article, plus have a look at the Campaign for Sepsis guidelines. Thanks very much.